Welcome to this explainer. We are jumping right in today because we're tackling one of the most common and, let's be honest, deeply frustrating challenges in everyday clinical practice, navigating referral pathways for the dizzy patient. You know, dizziness accounts for roughly 4% of all primary care consults and 3% of emergency presentations in Australia. That is a massive volume of patients. But despite that, the referral landscape is just surprisingly poorly developed. So let's explore how we can finally bring some structure, clarity, and precision to routing these patients, starting with a hard look at the data. Picture this for a second. Why on earth does a patient with classic vestibular migraine wait 6 agonizing months to see an ENT, only to get a perfectly normal audiogram? It's a frustrating loop, right? For the patient, for you, for everyone. It really just highlights a fundamentally broken system where patients are routinely sent to the wrong specialty, wait months for an opinion, or literally just get sent home without any working diagnosis at all. And the result of that broken system? It's this staggering number, 18 months. Based on consumer survey data from Bisdorf in 2013, the median time to diagnosis for dizziness in Australia is over a year and a half. These patients are seeing on average 3 to 4 different clinicians before anyone finally nails down the right diagnosis. But here's the real kicker. The vast majority of that delay, it's actually due to referral pathway inefficiency, not diagnostic difficulty. We're not waiting 18 months because these conditions are impossible puzzle boxes. We're waiting because the rate-limiting step is simply picking the right provider. So, here's our roadmap to fix this. 1. The dizziness referral problem. 2. Why dizziness is misreferred. 3. The 6 vestibular providers. 4. The vestibular physician model. And 5. Match syndrome to provider. Let's get right into it. Section 1. The dizziness referral problem, moving past the 18-month bottleneck. Now take a look at this first contact triage pathway. It really shifts our whole perspective. The goal of a referral is never just to confirm that a patient is dizzy. I mean, we already know they're dizzy. A referral needs to target a very specific clinical question. Maybe that's a diagnosis, a specific intervention, or risk stratification, stuff that just can't be answered in primary care. As you can see right here, most cases are actually diagnosable right at the bedside if you use a structured history like tick trait and exams like Hintz or Dix-Hallpike. So a referral should strictly be for diagnostic uncertainty, severity, or surgical pathology. Moving right along to Section 2. Why dizziness is misreferred. The structural gaps in the clinical pathway. So, why does this keep happening? Well, there are 4 massive structural gaps driving this bottleneck. First off, vestibular medicine has no single owning specialty. It kind of sits awkwardly right at the intersection of ENT, neurology, geriatrics, and rehab. Second, in the public system, non-surgical vestibular dizziness is routinely slapped with a Category 3 priority. And we all know what that means. An agonizing and frankly unacceptable 6 to 12-month wait. Third, Newman-Toker highlighted this back in 2008. There are huge training gaps. Very few first-contact clinicians are formally taught the bedside vestibular exam. And because of that low diagnostic threshold, we hit gap number 4. Referral letters that completely lack an explicit clinical question, basically guaranteeing the patient is going to be triaged poorly.
Section 3. The 6 vestibular providers, mapping the Australian vestibular workforce.
Okay, here is the absolute most crucial point to remember today. No single provider can manage every dizzy patient. General practitioners are first contact, and they remarkably manage up to 70% of cases. Vestibular physiotherapists are absolutely brilliant for BPPV maneuvers and balance retraining. Then you have the vestibular physician, offering a fantastic one-stop diagnostic consult with comprehensive testing. ENTs, they handle the surgical management, things like Meniere's or Schwannemus. Neurology takes on the heavy hitters, stroke, MS, and complex central cases. And lastly, audiologists provide that vital audiometry and specific testing that really supports our medical interpretation.
Let's circle back to GPs for a second, because get this, GPs can manage an incredible 60 to 70% of presentations without ever making a referral. Think about it, a single Epley maneuver resolves BPV in the vast majority of patients. Vestibular migraine, you can tackle that right in the clinic with the SEEDS framework and a prophylaxis trial. Neuritis really just needs hints to rule out a stroke followed by early rehab. And orthostatic dizziness, honestly, that often just needs a properly performed lying and standing blood pressure test and a quick medication review. Taking just 5 extra minutes to do these bedside assessments is literally the highest yield change a primary care clinician can make.
Section 4. The vestibular physician model, a new pathway for diagnostic uncertainty.
Now, let's talk about the vestibular physician, who is often a GP with special interest training. They act as this incredible bridge between general practice and those severely oversubscribed tertiary hospitals. So, when do you refer to them? Well, primarily when there's diagnostic uncertainty, even after you've done a structured GP workup. You also send them patients with refractory vestibular migraine, the ones who have already failed 2 adequate preventative med trials. They are also absolutely perfect for confirming suspected PPPD or persistent postural perceptual dizziness and getting a solid rehab plan in place. Oh, and they're great for community-dwelling adults with recurrent unexplained falls. But crucially, and I can't stress this enough, do not send them acute red flags. Things like sudden hearing loss or central hints still absolutely require immediate, same-day emergency stroke or ENT pathways.
Section 5. Match syndrome to provider. The golden rule of referral. If you take away absolutely nothing else from this explainer, let it be this. Dizziness as a standalone symptom is utterly useless for selecting a specialty. Dizziness never selects a provider. You have to map the specific clinical syndrome. And by syndrome, we mean the unique pattern of triggers, the duration of the episodes, and the targeted bedside clinical signs. That is what dictates where the patient goes. It's the golden rule.
And this matrix brilliantly illustrates exactly how to do that. It takes all the guesswork right out of the equation. If the syndrome is a positional vertigo failing the epilepsy, route them to a vestibular physio or physician. If it's suspected unilateral vestibulopathy with persistent imbalance, they go to a vestibular physician for VIT-HIT testing and rehab planning. But if they have recurrent vertigo plus hearing changes, that's when you've got to send them to ENT or neuro-otology to look for Meniere's or schwannoma. And if they show up with cerebellar signs or suspected MS, they go straight to neurology. You see how that works? Match the syndrome to the skill set.
To wrap this all up, remember that the median time to diagnosis is an unacceptable 18 months, and the real bottleneck isn't a lack of available providers, it's the choice of provider. We have got to stop writing generic referrals for dizziness and start targeting the specific syndrome. In the next explainer in this series, we're going to dive even deeper into choosing the exact right provider, detailing exactly when to utilize a vestibular physician versus ENT versus neurology, or when to simply keep the patient right there in primary care. To explore more dizziness, vertigo, and imbalance topics, and to access some incredible clinician resources, be sure to visit AustralianDizzinessClinics.com. Until next time, I'll leave you with this. Is it possible that the biggest bottleneck in your patient's care has simply been the referral letter itself?